I'm your host, Dr. William Dodd, from the East Tennessee State University Health Pediatrics Adolescent Medicine Clinic. This podcast is not intended to provide medical advice. If you or a loved one are working through medical problems related to today's topic, please consult a personal physician. I have no conflicts of interest to disclose. Today, I'll be serving as a guest on the show to discuss a very important topic, the treatment of depression with medication.
Hello, my name is Caylyn Yost, and I am the guest host of the Growing Stronger Together podcast today. I'm currently a fourth year medical student at Caylyn College of Medicine, and I will be interviewing with the residency programs in pediatrics as I am applying pediatrics. And today I am here with Dr. William Dodd, the usual host of this segment of the podcast. Dr. Dodd, welcome.
Thank you, Caylyn. It's a little bit different being on this side of the microphone, but yeah, for those of you who don't know me, my name is William Dodd. I'm board certified in both pediatrics and internal medicine, and I treat adolescents very frequently. I run the adolescent rotation for the residents and medical students, and our adolescent clinic here in clinic, ETSU Health. So I see a lot of teenagers, and I really been wanting for quite some time now to have a show about one of the more common things that we treat with adolescents and teenagers, namely depression, and some of the medicines that we use, some of the techniques that we can use to treat depression. I know we've had previous shows on kind of the incidence of depression and some of the things to watch out for, but this is more about medical treatment from the perspective of a general pediatrician. So when you go to your doctor, maybe some of the medicines that they have in their arsenal to use to fight this illness. And Caylyn, you're at a interesting time in your career. You're a fourth year medical student. You're about to graduate from medical school later on this year. How long do you anticipate being in residency?
Well, I will be in residency for 3 years, certainly, for pediatrics. And then beyond that, I maybe will do a fellowship. So that might be 2 to 3 more years of training, but three minimum.
That's such a long training program, but an important job. So I think a lot of people, you see TV shows about residency and that sort of thing, but a lot of people don't know about kind of the duration of medical training and just how many years of work it takes to be a attending physician. So thank you for agreeing to host the show today, Caylyn.
Absolutely. I'm honored to be here.
Well, like I said before, we'd like to talk about kind of some of the medicines that we can use to treat depression, kind of when we start looking at medicine, maybe some of the side effects of those medicines, and some of the things that go into the decision to start medicine for depression. So it's a good broad topic today. Yeah.
Is medicine your first line therapy for depression before you get into all the details?
It's a really good question. I think as a doctor, it's very tempting to prescribe medicine to treat illnesses. It's kind of the model that we practice in. It's a lot of times what patients expect. And if I had a medicine that would treat all depression, I'd be very happy to use it liberally. And medicines have a place in treatment. I think one of the issues that you run into with adolescents a lot of times is that life stressors just play such a huge role in adolescents' perception of self-worth and mood. So if they're getting bullied or picked on or having relationship issues or career issues, or they're not doing well in school, or there's family stress, a lot of times that can affect a teenager more than it would an older adult who's kind of been hardened by the world. so, uh, so yeah, I think it depends. A lot of times, adolescents may have a strong family history of depression and have an organic depression. The really like counseling will help, but really medicine is probably going to be part of the answer for that patient. And then other patients will have symptoms of depression more related to life stressors, for which I feel like counseling is probably a better choice to start with treatment. And then sometimes you have kids who have very severe depression with risk of self-harm, or it's severely impacting their lives or schooling or relationships. And those kids, might need to approach depression from both counseling and medicine side. When a patient comes to me with depression, if I'm starting medicine, almost invariably I will also ask that they attend counseling, because medicine and counseling work in different ways, and counseling is as effective at treating depression for adolescents as medicine. So it's a complicated choice a lot of times, and a choice that needs to be made between the pediatrician and the family. But it's definitely not a choice that I take lightly, or medicine is not always the first line option for treatment of depression.
Sure. And when medicine does kind of fit into the clinical picture based on each individual patient, what medicines are you reaching for to treat depression in these teenagers?
So I think is general knowledge that there are a lot of medicines that work on depression and anxiety and kind of mood stabilizer options for adults. As a general pediatrician, my options are somewhat limited, though. I try and stick with medicines in a class called SSRI. Those are selective serotonin reuptake inhibitors. They basically increase the level of serotonin, which is a neurotransmitter in the brain, to combat depression. And there are 4 medicines in that class that have been either well studied or approved in teenagers. Probably the granddaddy of them all is fluoxetine or Prozac. Fluoxetine is a older medicine. It was kind of the first of that class way back when, and so it's been around forever and is well studied, well tested. There's a medicine called sertraline, which is very popular in certain adult populations. It's a really good treatment option. And then there's some newer medicines, citalopram and escitalopram. Those are related compounds. They're newer antidepressants, and I've had patients for whom they are very effective as well.
Amazing. Well, it sounds like there's a plethora of options.
Yeah.
How do you pick between these options of medications, this SSRI family?
So they all have a little bit of a different characteristic. You never know how a medicine is going to affect a patient until that patient takes the medicine and it interacts with their brain and body. And, all bets are off. You can just kind of guess at a medicine that might be a good choice for the patient. Fluoxetine, the one that's been around for a while, is a really good choice initially for a lot of patients because it has what's called a really long half-life, so the body's slow to metabolize it. So if a patient misses a dose, they're not going to be on a roller coaster of the medication effect as much as some of the other agents, which are shorter acting. So a lot of times as initial therapy for an adolescent, I'll try fluoxetine. It's been around forever, lasts a long time, resistant to timing and missing doses. So that's a reasonable first-line choice. Sometimes some of the newer medicines, citalopram and escitalopram, are a little bit better for anxiety. So sometimes if you have a patient who's very anxious, I might try one of those. And then finally, if they have a family member who's on a medicine that seems to really work, sometimes you'll start with that medicine. And so many of the genes that metabolize these medicines are shared and they run in families, and so many medicines kind of work similarly for patients who might have a parent who's on a medicine. So if a parent says, I'm on sertraline, it works really well, maybe we should try sertraline.
That's awesome. And then with these medicines, what are some of the drawbacks or, side effects associated with these medications?
So I think, number one, anytime you're prescribing a medicine to a patient, especially a more chronic medicine that you need to take every day for longer term, that's a big decision for that patient. And, just the act of having to worry about taking a medicine, having to purchase medicine, having to continue and keep up with the medicine, you're asking quite a bit of an adolescent a lot of times. Also, any of the SSRIs, or really any medicine in general, can cause GI distress, so nausea, a little bit of diarrhea or loose bowels or cramping or decreased appetite. So these medicines a lot of times will cause those side effects up front. Usually if patients stick with the medicine, if it's starting to work for depression, those side effects get better over time. So a lot of times I'll tell patients to try and stick with it and try and move through it. Sometimes you have patients who just don't respond well to a medicine. They have trouble sleeping, or they have, nerve tingling sensation, or I've heard any number of just kind of unusual side effects of these medicines. And I always tell a patient, if the medicine doesn't do well by you and it's pretty clear that it's going to cause some bad side effects, let's just back off and pick a different agent. And sometimes you just have to try 2 or 3 of them in sequence before you figure out what works for a patient. And finally, with any SSRI medicine in teenagers and young adults, the FDA has issued what's called a black box warning, where these medicines could potentially cause some harm in the form of self-harm thoughts or behavior. So I always warn parents about that.
Oh, yes. Could you tell us a little bit more about the black box warning, and what that means for patients?
Sure. So black box warning, when the FDA has a medicine where they've noticed a signal that might present some harm to the patient, however, the medicine overall needs to be available and seems to be effective. If there's some element of risk to the medicine, they'll put out what's called a black box warning, which is essentially consumer labeling that informs patients of a risk and is prominently featured on prescriptions, and is something that needs to be talked about by doctors when they're prescribing the medicine as well. So the black box warning for adolescents and young adults with SSRI class medicine is that these medicines may increase self-harm thoughts or behavior. And this black box warning, the signal, has kind of been cobbled together by numerous studies that notice that a certain percentage, under 10% of patients who are younger, who start these medicines, have some thoughts surrounding self-harm. The studies use different methods to measure this, and different definitions of this risk. So it's a little bit hard to exactly pin down what's going on, but it does seem like that risk is present for a small percentage of patients who start these medicines. That being said, though, self-harm is a symptom of depression, and particularly untreated depression. So if I have a patient who's severely depressed and considering medicine, who needs medicine to treat their depression, that risk is likely outweighed. The risk of the black box warning of the self-harm thoughts is likely outweighed by the benefit of treating that depression, reducing the depression, reducing the risk of self-harm in the future. Also, there are pretty good epidemiological studies from other countries where they took everybody who started medicine in the SRI class, who's in this age range, and measured rates of suicide within the age range for patients who were or were not taking the medicine, and they were unable to find a difference in the rates of self-harm and rates of suicide amongst patients who start SSRIs. So even if patients are having some thoughts of self-harm, maybe the mechanism's unclear, but maybe they're severely depressed and their depression gets a little bit better and they're able to have energy to contemplate self-harm even. So it might not be a direct effect of the medicine. It might be a manifestation of their depression that's treated in a gradual and changing way by the SSRI medicine. So it's really unclear. I always talk with families, and I talk with patients about this risk. And there are some things that you can do to mitigate that risk. We always like to reduce any access to firearms or medicines a patient could overdose on. That's true for any depressed patient, but particularly patients that you are starting a medicine. You want to make sure their home environment is safe and they don't have access to a way that could easily harm themselves on the spur of the moment. Adolescents have poor impulse control, and you always worry about that. And then you also want to do a little bit of crisis planning, talk about crisis hotlines like 988 would be the new big one. Anybody can text or call 988 on a cell phone and reach a crisis hotline for any sort of mental health crisis. And also clinic-specific and location-specific options for any sort of mental health crisis.
Well, it sounds like there are some great ways to mitigate the risk of self-harm in depressed patients, which is awesome. One question I have is, once these patients are started on a medication for depression, do they typically need to stay on it long-term? Is it more of a short-term thing? How does that work?
So that's a really good question, and I feel like it's a little bit complicated by the fact that depression, screening positive on a depression form, being diagnosed with depression it's a medical condition, but it's also a symptom. It's like cough. If a patient comes in with cough, is it allergies? Is it asthma? Is it pneumonia? Is it something else that's causing this cough, this symptom? And kind of depending on the underlying cause, that kind of guides what sort of treatment that patient's going to need longer term. And depression's the same way. If a kid's in a hostile environment, if they're dealing with big personal stressors like really bad relationship issues, questions of sexuality or gender identity, or career problems or friend problems, that are driving their symptom of depression, even though they're diagnosed clinically, even if they might even require medicine, it really depends on that patient's situation and trajectory as to whether they're going to need the medicine long term versus somebody who's biologically depressed. Their brain just works in a way that makes them depressed. They might need medicine long term. Usually for adolescents, we'll start a medicine. If they need a medicine, we will start the medicine. We will titrate to effect, so increase the medicine to the point where either they're having side effects or it's working. And then once you're at that point, probably continue for a good 9 months or a year or even longer, depending on how bad things were, before you would pick an opportune moment. Maybe the kid's off for the summer. Maybe they're in less stressful classes where you would try and reduce the medicine and have some frequent follow-ups, see how they're doing, try and get them off the medicine. But it really just depends on what's driving that kid's depression, what symptoms they're having, how much they benefit from medicine as to whether you continue it long term. But I would also clarify that these medicines are not addictive. They can be stopped at, they can be tapered down and stopped at any time. A lot of parents are worried that their kid is going to get hooked on a medicine. But that's just not the case with these medicines. They're not habit forming or anything like that. They're just medicines that treat a symptom. If you need it, you need it.
And let's say you do have a patient that you start on a medication for their depression, and it's not working for them. It just isn't the medicine for them. What is your strategy for switching that medication?
Yeah, that comes up all the time. If a patient is on a low dose of the SSRI and tolerating it well, and it's not having the desired effect after about a month, my first move would be to recommend that we increase the dose of the medicine, because sometimes, adolescents, everybody's liver works differently, so it metabolizes medicines differently, and then also everybody's a different size, and our brains respond differently to medicine, so they may just not be on an effective dose. So usually I'll titrate it up until you have a really good dose or you reach the effect that you want. If a patient doesn't respond to the medicine or has side effects and you want to switch to a different one, you don't want to combine these medicines. So typically, and this is very conservative, but it's also safe, what I'll do is I will slowly taper one medicine over the course of a week or 2 weeks if they're on a higher dose. So they would take a reduced dose for a while, and then another reduced dose, and then stop and have a washout period of several days before titrating the next medicine up slowly. If a patient's severely depressed, or if they're seeing a psychiatrist, oftentimes they will do what's called a cross taper, where they'll taper one medicine while simultaneously increasing another medicine. But I feel like that's a little bit out of my wheelhouse, and a lot of times, I'll try and do the washout period and slow taper type method.
You mentioned your wheelhouse, which I also have a question about. As pediatricians, we definitely have a scope of practice. And what is your threshold / when do you tend to refer patients to psychiatry?
And that's a really good question too. First off, if a patient requests a referral to psychiatry, I'm always more than willing to do that. I think patients should have a voice and a say as to who's treating them for any condition, but especially mental health conditions. And if they want to work with a psychiatrist to figure out a reasonable treatment plan, I think that's totally reasonable. Usually, if I have a patient who has severe depression, or depression that's comorbid with something like autism that can complicate depression greatly, or depression that you're concerned might be bipolar in nature, and that this patient may have some hypomania or mania type symptoms, trouble sleeping, grandiose thoughts, things like that. If it's a little complicated in that way, I would send a patient to psychiatry. If I've tried, 3 different agents and none of them are effective, and we're looking at things that aren't as well studied in adolescents, I would recommend they see a psychiatrist. Or if it's more convenient for them and they're established with an organization, these big mental health organizations oftentimes provide counseling services as well as medication management. Sometimes it can help to have both those treatment teams under the same roof and talking with each other. So if a patient's well established with therapy and they really like it, and they have a little bit more complicated medicine course, I think it's fine for them to see a psychiatrist. I would never resist a patient's need to see a specialist in this area, because mental health is so complicated.
Absolutely. Well, Dr. Dodd, thank you so much for joining us today and being on the other side of the microphone and giving all of us some great information on depression and treatments for depression in teenagers. It's been a great conversation. I appreciate you.
Well, thank you. Thank you for hosting, Caylyn. Best of luck in your medical education journey.
Thank you. Thank you.
And I hope our conversation has been useful to folks who see adolescents with depression either in our work or our families, and are kind of making this decision, medicine versus no medicine, or kind of knowing a little bit more about how things work from that end. So I've enjoyed our conversation. Thank you, everybody, for joining us today.